Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for our presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker today, Dr. Jana Sanders. Dr. Sanders is a PGY3 internal medicine resident here at Northeast Georgia Health System and originally from Georgia. She earned a Bachelor of Science degree from Brenau University, followed by a Master of Biomedical Sciences from the Philadelphia College of Osteopathic Medicine in Suwanee, Georgia. And then she went on to complete medical school at Mercer University School of Medicine in Savannah, Georgia. After residency, she will be working as a hospitalist. Join me in welcoming Dr. Sanders.
Hello, I'm Jana Sanders, and today we're going to be talking about the GLP-1 revolution, mainly transforming cardiometabolic disease. So for my disclosures, I don't have any. No one pays me for anything. Our objectives, so first we're going to review the incretin physiology, then we're going to describe the GLP-1 receptor agonist mechanism, examine and summarize landmark clinical trials, identify expanding indications, discuss safety and future directions, and apply GLP-1 therapies to clinical practice. So first, we'll start with a clinical case. This is a patient that most of us see in the clinic, 52-year-old woman, BMI of 38. She's got hypertension, prediabetes. She's tried lifestyle interventions in the past that have not worked, and she has not tried any prior pharmacotherapy for weight loss. So what pharmacological options exist today? So we can think about that question as I go through this. So why obesity matters? Over 40% of United States adults have obesity today. This is now considered an epidemic across the United States. And what's even more important is that obesity is not just a risk factor, it's a central driver of cardiometabolic disease, leading driver of diabetes, cardiovascular disease, and mortality. So these are some obesity charts. So this chart, this is from the NCHS. Essentially, we're just looking at the green lines right here, which shows obesity over time. So it starts in like the 1960s and goes into like 2018. But that's a pretty big climb. And then over here on y'all's left, I guess, no, you're right. This is from the CDC 2024 map that essentially shows exceeding rates of obesity. Around 30 to 40% of America is obese. So for our historical treatments, obviously we have lifestyle modification with diet and exercise. This usually fails due to long-term durability. You know, people's lives change. They're not going to keep working out and exercising the same all the time. Some pharmacotherapy that we had, orlistat, we only saw around a 3 to 5% weight loss with that. And then phentermine, you can only use that short term for weight loss. And then other agents have been limited by side effects. And then obviously we have bariatric surgery. This is the most effective intervention, losing around 25 to 30% of weight loss. But obviously it's invasive, limited accessibility with, financial reasons, stuff like that. All right, so now we'll talk about the mechanism of the GLP-1 hormone. So we're going to digest food, goes into the small intestine, our L cells on the apical surface down here. It absorbs like glucose, fructose, galactose. It's absorbed in, and then that opens the potassium channel, allows for depolarization for the calcium channel to activate proteases to cleave proglucagon into GLP-1. And then that goes to the pancreas, and from there we'll talk about the other effects. So one of the main things too is that our endogenous GLP-1 sharply raises with a peak of 30 to 60 minutes following the nutrient intake, and the half-life is just 1 to 2 minutes in the bloodstream. All right, so for our incretin system, we do have two gut-derived hormones after meals, our GLP-1, which we all know, the glucose-like peptide, and then our GIP, which is glucose-dependent insulotropic polypeptide, but we're mainly going to focus on GLP-1, so mainly this side. So our key physiological effects here is it's going to increase insulin secretion, decrease glucagon, increase satiety, and decrease gastric emptying. And that's pretty much what this figure shows, increased satiety, decreased food intake. The pancreas increases insulin, glucagon, the stomach, gastric emptying, and then systemically decrease hyperglycemia. So the mechanism of GLP-1 receptor agonists, essentially it mimics our endogenous GLP-1, but it has prolonged activity. So GLP-1 receptor agonists, they're engineered to resist degradation, giving them much longer half-lives, usually lasting days. And then the result is improved glycemic control and reduced caloric intake, leading to weight loss. So currently, some available drugs, I did not list all of them because there's a lot, and we're mainly just going to focus on two in this talk, but some of them, liraglutide, semaglutide, dulaglutide, and then we do have a dual incretin therapy, tirzepatide, which is a GIP-1, or a GIP and GLP-1. So down here, because I know, oh gosh, sorry. I know that we use a lot of brand names. So our semaglutide is going to be Ozempic, Wegovy, Rybelsus, tirzepatide, Mounjaro, Zepbound, liraglutide, Victoza. I've actually never seen Saxenda. And then dulaglutide is Trulicity. So the current FDA approved indications for GLP-1 is obviously diabetes. That was like the first approval. So we won't be doing too much about diabetes, more focusing on everything else. Obesity and chronic weight management, that is approved now for a BMI over 30 or a BMI over 27 with a comorbidity. And then cardiovascular risk reduction, and then we'll be talking about the SELECT trial, but that's in patients without diabetes, so truly just cardiovascular risk. And then emerging expanding indications, HFpEF, CKD, and MASH. All right, so for our semaglutide, this is a long-acting GLP-1 receptor agonist, once-weekly dosing. Indications are type 2 diabetes and obesity, and then our key effects are decreasing hemoglobin A1C and seeing about a 15% weight loss per the STEP trial that we'll talk about. Tirzepatide, dual incretin agonist, GLP-1 and GIP, once-weekly dosing, just like semaglutide. And then the indications for that one are the same as well, diabetes and obesity. And then the key effects here are decreasing hemoglobin A1C, but here we see a greater percent of weight loss, 20% rather than 15%. All right, so this is just a chart I made because we're going to be focusing on these two. So just to show, the differences between them. All right, so one of the most striking aspects of these therapies is the magnitude of weight loss. So historically, lifestyle interventions and older medications produce modest reductions, typically in the range of 3 to 10%. However, with semaglutide, we now see weight loss approaching 15% and tirzepatide around 20%. This represents a significant shift in what we can achieve with pharmacological therapy. So now we'll look at some of the trials that establish this data. So first, we're going to talk about the STEP trial. This is semaglutide. This is a phase 3 trial, so I just added this in. They're pretty much all phase 3, so this is just kind of a overview of what that is. So in phase 1, it's all about safety, kind of small group. Phase 2, they start looking at dosing, early efficacy. Stage 3 is large-scale efficacy and safety. And then stage 4 is post-marketing surveillance. So this one, this program, STEP trial, it was patients without diabetes. And it was weekly semaglutide versus placebo, and the primary outcome is the percent of weight loss. All right, so step 1 trial, semaglutide in obesity, again, it was a 3-phase trial, randomized, double-blinded, placebo-controlled, adults with obesity without diabetes. They did semaglutide 2.4 milligrams weekly versus placebo, and the duration was around 68 weeks. This one was also done, sorry, I forgot to mention, this was done in 2021. So over the 68 weeks, patients treated with semaglutide achieved a mean weight loss of nearly 15% compared to 2% in the placebo group. And importantly, there wasn't just a small subset of patients, nearly 70% achieved at least 10% weight loss, and about half achieved 15% or greater. These results are unprecedented for pharmacological therapy and significantly change expectations for medical weight loss. So here is the results from our STEP trial. Up here we have placebo, down here we have semaglutide, change in baseline, and then this is just the weeks. So obviously you can see weight decreasing, and then this is also body weight change decreasing. And then on the bottom down here, this is just how the percentage of weight loss. So semaglutide, less than 5%, almost 86% of people had greater than 5%. And then I think the really big thing is that people who had greater than 15%, it was around 50% of the people. Okay, so just for completeness sake, the additional step 2, step 3, step 2 was essentially patients with type 2 diabetes, semaglutide versus placebo, 9 to 10% weight loss, so not as much, but still significant. And then step 3 was semaglutide versus intensive lifestyle modifications. And then what we saw in that one is essentially greater weight loss than lifestyle alone. All right, so step 4, this is the maintenance of weight loss. So again, all these studies are phase 3 trials, randomized, double-blinded, placebo-controlled. This is with adults with overweight or obesity. This is a 20-week semaglutide run. And then after 20 weeks, they're randomized into continuing semaglutide or essentially doing a placebo. And this was for 68 weeks. So pretty much what they saw is that we need to continue semaglutide. You have ongoing weight loss, and then with the placebo, there was actually weight regain. So discontinued therapy gained around 6 to 7% of body weight back after discontinuing the GLP-1. So this is the results from step 4. So this dotted line right here, that's going to be the 20-week mark where they randomize them and switch them. And we can see the people on the placebo gained more weight, and people who continued semaglutide continued to lose weight. Okay, so that was semaglutide. Now we'll talk about tirzepatide and obesity. Phase 3, randomized, double-blinded, placebo-controlled. This was looking at adults with obesity or overweight without diabetes, but just for tirzepatide, not semaglutide. So tirzepatide, they did 5, 10, 15 milligrams weekly versus a placebo over 72 weeks. This one was in 2022. And over the 72 weeks, patients treated with tirzepatide achieved weight reductions of up to 20% compared to 3% with placebo. A substantial portion of the patients achieved clinical meaningful weight loss up to 50 to 60% of weight reduction. All right, and then this is the results from that trial. Up here we can see placebo, and then even the 5 milligrams, 10 milligrams, and then the 15 milligrams. Same with this, 5, 10, 15, and then the placebo, and then essentially same thing. You can see though that the placebo is clearly down in all of them, and there's significant weight loss. Okay, so that was for obesity. Now we're going to go into cardiovascular risk and how GLP-1 plays a role here. So obesity is the central driver of cardiovascular disease, contributing to conditions such as hypertension, dyslipidemia, and insulin resistance. These factors collectively increase the risk of atherosclerotic cardiovascular disease, including myocardial infarction, stroke, and heart failure, particularly HFpEF. So this essentially raises an important question. If we effectively treat obesity, can we reduce cardiovascular risk? And then in this figure right here, we got obesity at the top, which contributes to hemodynamic factors. It can increase our afterload, which increases our blood pressure, causing concentric left ventricular hypertrophy. It can also increase our preload, our blood volume, which can cause eccentric left ventricular hypertrophy. And then non-hemodynamic factors over here, mitochondrial dysfunction, hyperglycemia with insulin resistance, inflammation, and liposity. So that all contributes to congestive heart failure. So the SELECT trial, this is looking at cardiovascular outcomes with semaglutide. Again, phase 3 randomized double-blinded placebo. This is adults with overweight and obesity with established cardiovascular disease. No diabetes was included in this one. So they did semaglutide 2.4 milligrams weekly versus placebo. This one actually was a long one, around 3 to 5 years. And then the primary outcome was decrease in major cardiovascular events, including cardiovascular death, non-fatal MI, non-fatal stroke. And our results from this was around a 20% relative risk reduction in cardiovascular events, consistent with benefits across subgroups. So this is the results from the SELECT trial. This is primary cardiovascular composite endpoints. We can see semaglutide reduces that versus a placebo. Death from cardiovascular causes, semaglutide also decreases that. Heart failure composite endpoint, we see a decrease, and then death from any cause, a decrease with semaglutide. So heart failure particularly preserved ejection fraction, so HFpEF, that's what we'll call it. It accounts for around 50% of all heart failure cases, and it has an increasing prevalence. Strongly associated with obesity, hypertension, diabetes, and then characterized by systolic dysfunction with a preserved EF. There's historically been difficulty treating HFpEF, limited medications for that. So this is the STEP HFpEF trial, semaglutide and HFpEF. Randomized, placebo-controlled, patients with obesity and HFpEF, semaglutide versus placebo for 52 weeks. And then how they measured this was with the KCCQ, which is the Kansas, I have it somewhere. It's like Kansas City Cardiovascular Myopathy Questionnaire, which essentially just goes based off symptoms in patients. So like shortness of breath, dyspnea on exertion, orthopnea, quality of life, able to function in life kind of thing. So that was the primary outcome, to see improved symptoms in the KCCQ. And then improved exercise capacity in the 6-minute walk test. And then what they found is there was significant improvement in heart failure symptoms, as well as functional status, and then greater weight loss versus a placebo. And then that's our results from this trial. So changing KCCQ. So the higher the KCCQ, the better the score. So like 100 is like you have no symptoms, and then 50 is like you're still struggling with some symptoms. So semaglutide clearly increased, and then the change in body weight versus placebo. All right, so that was heart failure. Now we'll talk about CKD. So GLP-1s and kidney disease. So this is the FLOW trial. So they looked at patients with obesity, I'll go back to that. So patients with obesity and diabetes are at risk for CKD. So the potential benefits that they wanted to show is decrease in albuminuria, slower decline in eGFR, and decrease in progression of kidney disease. So the clinical evidence here is that it did show decrease. So we can go to the results. A lot of these are just like first major kidney event. I would say we can look at this one, the eGFR slope. So with the placebo, it goes down at a higher rate versus with semaglutide. And then these are the cardiovascular. This is first major kidney event with semaglutide decreased, and then kidney-specific semaglutide was decreased. Okay, so from the kidneys going to the liver, MASH, metabolic dysfunction associated steatohepatitis, formerly known as NASH. So this is strongly associated with obesity, type 2 diabetes, metabolic syndrome, and then the potential benefits of GLP-1 therapy that we're looking at is decreasing hepatic steatosis, as well as improvement in liver function, weight loss, which would be the key driver in these. So there have been a couple of trials out. I picked this one from 2021, which essentially shows complete resolution of steatohepatitis without worsening of liver fibrosis. This is with a GLP-1 versus a placebo. And this is reduction, so not resolution, but reduction. And it's still significant with a GLP-1. All right, so our adverse effects of GLP-1 receptor agonists, these are the most common GI-related effects. So nausea, vomiting, diarrhea, constipation. And then the main thing is that with these, it's typically dose dependent and often transient. So usually we increase the dose at a slower rate so that they don't have those symptoms. And then the serious risk and safety considerations. So pancreatitis it is rare, but usually we do try and avoid that, a GLP-1 in people with pancreatitis, gallbladder disease, and then absolute contraindications would be medullary thyroid carcinoma and MEN2 syndrome. And then we use caution, like I said, with history of pancreatitis and definitely with severe gastroparesis since it slows gastric emptying already. So these are some emerging under-recognized risks. Our body composition, so lean mass loss, around 25 to 40% of the weight loss was lean mass. That can impact our muscle strength, frailty, especially in the elderly. And then bone health, still emerging data coming on this, but possible decrease in bone density, and then long-term fracture risk is not clear at this time. And then nutritional effects, decreased protein intake, risk of sarcopenia. So our key concept is not all weight loss is metabolically equivalent. So for the lean mass loss, there actually was a study by Bastis and colleagues evaluating the incretin-based therapy effect on compared to lifestyle modification. So they found that approximately 1/3 of total weight loss may come from lean mass, but importantly, this was not unique to a GLP-1. They also saw that in patients with lifestyle interventions. So, however, many studies do show exceeded expected threshold for muscle loss, which raises an important question about long-term functional outcomes. All right, so again, these are just like the main ones. There's obviously other GLP-1s. So this is just dosing. Wegovy goes from 0.25 to 2.4. Zepbound goes from 2.5 to 15. Mounjaro, same, 2.5 to 15. And then Ozempic, 0.25 to 2. And then this just kind of gives you, usually start on 4 weeks, increase at 5 weeks, and kind of gradually go from there so they don't have side effects and can tolerate the medication. So the biggest issue with these medications, I think, is cost and access. They're very expensive right now. So they're around $800 to $1,200 a month if your insurance won't pay for it. And then the barriers are essentially insurance coverage. Prior auths are required, which can, take some time. Limited access for many patients, and then drug shortages and high demands of these drugs. So what's going to essentially help this is when we have long-term outcomes that are confirmed, as well as more data that will help make these a little bit cheaper. So the public health implications of GLP-1, again, like we talked about earlier, obesity affects over 40% of adults in the US. So the impact of this is we could potentially decrease our cardiovascular disease burden, decrease type 2 diabetes incidence, and decrease our healthcare utilization. So this picture I actually got from the CDC in 2024. That just shows estimated annual medical costs of obesity is around $147 billion, which is insane. The medical costs for obese individuals are around $1,400 higher than normal weight. And then they spend about 42% more on direct healthcare costs than the average weight person. And then healthcare costs for severely or morbidly obese adults are 81% higher than healthy adults. So clearly there is a burden on the healthcare system with obesity. Okay, so now we can talk about pharmacotherapy versus bariatric surgery. So there's actually no large head-to-head random control trial that definitively compares GLP-1s versus bariatric surgery, but there have been a couple meta-analysis, so this data is from those. So for our GLP-1, again, semaglutide 15%, tirzepatide around 20%. It's non-invasive, but chronic therapy is required. And then, our cost, access, and adherence is an issue for that. But then bariatric surgery, this is still the most durable weight loss. It's around 25 to 30% total. And then they have long-term metabolic benefit, but it is invasive, perioperative, and nutritional risk with that. All right, so future directions of the incretin-based therapy. So they do have a triple agonist, which is a GLP-1, a GIP, and glucagon agonist. The name of it is retatrutide. I looked that up on YouTube. And it's showing around weight loss up to 24% in early trials, which is really good. And as we saw with bariatric surgery, it's 25 to 30%. So 24% is reaching bariatric surgery level. And then additional, we can do, it's kind of like a combination approach. Maybe we have people who want to do bariatric surgery, we put them on a GLP-1 first, then they can get bariatric surgery, continue after, or we can even do GLP-1 after bariatric surgery. All right, so our future indications for hopeful FDA approval are HFpEF, our CKD that we talked about, liver disease, MASH, OSA, obstructive sleep apnea, and then definitely I think the coolest one is the neurological with Alzheimer's disease and addiction reward pathways. All right, so from a clinical perspective, GLP-1 receptor agonists should be considered in patients with obesity, definitely BMI greater than 30 or BMI greater than 27 with comorbidity. These therapies offer significant benefits, including weight loss, cardiovascular risk reduction, and potential multi-organ effect. However, we still have to consider cost, long-term effects, and access remain important. All right, so we can follow back up with our case. Returning to our patient, she was started on a GLP-1 therapy with weight loss and improved labs. Outcomes after 6 to 12 months, a 10 to 15% weight loss, improved blood pressure, improved glycemic markers, and then the clinical impact is improved symptoms and reduced cardiometabolic risk. So in summary, GLP-1 receptor agonists represent a major advancement in the treatment of cardiometabolic disease. They produce significant weight loss, demonstrate cardiovascular benefit, and increasingly being used across multiple disease states. However, they are long-term therapy and challenges related to cost and access. These therapies are not just changing how we treat obesity, they're changing how we think about cardiometabolic disease. Okay, so now we'll do some questions. Oh, should I read it? Okay. Which of the following statements regarding GLP-1 receptor agonists is true? A, they produce weight loss primarily through increased energy expenditure. B, they are the only indicated for patients with type 2 diabetes. C, they have demonstrated cardiovascular benefit in patients without diabetes. Or D, they result in permanent weight loss after discontinuation.
What does everybody think? I see a couple, C?
Okay, that's correct. Good job. You guys listened. Okay, we'll do one more. Which of the following is an emerging concern with GLP-1 based weight loss? A, excessive increase in muscle mass. B, predominant fat-free mass gain. C, loss of lean body mass during weight loss. And D, immediate increase in bone density.
C again is what
C
we're
again.
going with.
Good
Very
job. Always pick C. Okay, so my acknowledgements, thanks to Dr. Gross. My man, he's stuck with me the whole time, got me through residency. We got 5 more weeks. Yes, thanks, Dr. Gross, you're the best. These are my references, and now I will take any questions.
Yes, thank you so much. Oh, we have a hand raised already.
Thank you, Dr. Bird. That was very nice. Very eye-opening. I wanted to ask, through your literature search, did you find any data on loss in bone mineral density before starting a GLP-1 agonist versus after, since you have about 30% loss in lean muscle mass?
Yeah, so that is some of the benefits that we don't know about yet. That's like a long-term outcome that we're still looking at. But the good thing is that even though with GLP-1 you lose lean mass, in the one of the studies I showed, that was not significant for GLP-1. It was happening with lifestyle modifications too. So you don't just lose adipose tissue when you lose weight, you do lose lean mass. But the bone density, that's emerging data that they're looking into that
Right,
could
like
be
a
a
DEXA
serious
scan.
risk.
Right, like a DEXA scan before and after.
Yeah, I didn't see anything like that yet, but I'm sure that they're going to be doing that.
Awesome, thank you.
Of course.
Thank you, Dr. Bird, for your presentation. Just wanted to, I feel like for GLPs specifically, a lot of people get lost into cancer risk, the diabetic retinopathy, they get lost into all these minor side effects, or not minor, but just on the rarer spectrum. Although one of the things, as you noted, that are straightforward, hey, you're gonna lose lean muscle mass. That's associated with increased morbidity, increased mortality. So I think there is some research going on for medications that you can take along with the GLP-1s that can reduce the muscle loss. I think they're still in phase 2 trials. I don't know if any made it to phase 3 trials yet, myosin inhibitors and other anti-activin 2 receptor inhibitors. I think these kind of things will go a long way. That being said, I do think also muscle loss will result in people rebound weight gain when they stop the GLP-1s because you already lost something that was helping you contribute to your metabolic rate and help you lose weight on your own. So, alluding to a question, what do you think about discontinuation of GLP-1s? Do you, in your practice, do patients reach targets in terms of weight loss and you're okay, let's see if we de-escalate it, or if it works, let's keep it on? What are the data on how likely are you to rebound weight loss, and what's your experience with that in your practice?
Yeah, so actually I'm just gonna go back really quick. So there was a trial I mentioned that essentially showed maintenance of semaglutide and how, I think it was right over here, how they did gain the weight back. Yeah, right here. So this is a 20-week mark. So they were all on semaglutide until then. And then at 20 weeks, they were randomized into placebo or to continue semaglutide. So the people with the placebo did gain weight back pretty significantly. It was around a 6 to 7% increase in their weight. So I think right now, this is a long-term therapy. I think we need to think of GLP-1s like hypertension, diabetes, high cholesterol. Obesity is a relapsing disease. It's not, I think that there's not misinformation, but I think that people look at obesity as like not a metabolic problem, and it really is. And so for this, I mean, it's like you have someone on blood pressure medications, their blood pressure looks good, you're not gonna take them off. So with a GLP-1, we kind of have to think of it like that. We're not gonna take them off of it because we know that it will result in weight rebound gain, and it's a long-term therapy. But my patients in clinic, I mean, they're on GLP-1s and they have no problem with it. We've never discussed stopping it. I do have one patient, her BMI is down to like 20, so I have discussed stopping that with her. But she's pretty adamant about continuing to take it. At least we just decrease the dose. But once you get skinny, no one wants to go fat again, We all love being skinny. Anyways, so that's my answer.
Thank you.
Thank you, Jana. Appreciate you doing the full scope, broad perspective view of GLP-1s. We've presented on this topic, of course, because it's one of the emerging classes of medications, kind of like statins were a few decades ago. So appreciate it, all-encompassing talk. And that was an excellent question and point that Yakut brought up. And I think it just reinforces the fact that behavior change is so difficult, and this medication effectively enforces behavior change, and people don't change. So when they get off the medication, they go back to their old habits and regain the weight. And plus the loss of muscle mass makes it more of an uphill battle. But I went to the ACP recently, and this was definitely a big topic. They were talking about the lean muscle mass loss and how to interpret that, and there was some emphasis on physical activity, especially resistant exercises, and diet for how to combat this given the prevalence and use. Yeah, it's exciting to see. You make a good case for it with very few side effects, although those are real side effects and a lot of people cannot tolerate. But I guess it remains to be seen, still overriding benefits. Maybe one hypothetical, real situation you probably deal with in clinic. What happens when someone without an indication, BMI 25, wants it for cosmetic use? What do you tell them?
I mean, are they going to a wedding? Is the dress satin? Like, that's a joke. That's difficult. I mean, BMI of 25, it's not even indicated for less than a BMI of 27 unless they have comorbidities. So at that point, I think I would focus on lifestyle modifications with that patient. But, these days you can go on the internet and get a GLP-1. I mean, of course, we don't know everything about that, but I'm just saying, in the clinic, I would try and push them more toward lifestyle modifications right now. But I think once they hit that BMI over 27 and they do have comorbidities, I would definitely want to get them on a GLP-1.
And on a similar note, have you noticed any of your patients kind of getting GLP-1 agonists through the general marketplace, like avoiding prescriptions via professionals like you and just getting it themselves?
None of mine do, because now we also have the oral Wegovy. So even if they don't get approved through insurance, I still try and get them the oral Wegovy, and that's only $150 a month. So that's much better than $1,200 to $800. But if they can't afford it, then I'll go the oral option. But I personally don't have any patients right now who are on it outside of me prescribing it.
Thank you so much for your excellent talk.
Yes, thank you guys.
Thank you, everybody.